Welcome to the Egg Whisperer Show, a podcast exclusively designed to create more reproductive health awareness and discuss your fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
Welcome to the Egg Whisperer Show. I have special guest, Dr. Sara Nowakowski, on today's show to talk to us about sleep and your fertility. Welcome, Sara.
Thank you for having me.
Sara is an associate professor at Baylor College of Medicine, and she treats patients with insomnia and other sleep disorders at the Baylor Sleep Medicine Clinic. She is also a research health scientist at the Houston VA, where she conducts research on sleep and women's health. Sara recently completed a study examining a cognitive behavioral therapy, also known as CBT, intervention for insomnia and nocturnal hot flashes in midlife women. And her current NIH-funded research aims to assess the efficacy of CBT for insomnia in patients undergoing hip or knee replacement on functional recovery. I am just over the moon happy that Sara's here to talk to us about sleep and fertility. There's no one better to do this today. Thank you again, Sara. So after getting a degree in clinical psychology, what drew you to study sleep?
Actually, I was studying sleep before I went to graduate school. As a lot of people in sleep, I fell into it, and I was an overnight sleep technician. So I worked overnight and did the little hookups that we do on people to diagnose sleep disorders. And that got me really interested in sleep and started pursuing it more and decided to go to graduate school, really looking at sleep and women's health. So from the get-go, for the past about 20 years, I've been studying sleep and women's health.
Wow. And we know sleep is so important. And in fact, when I talk to my patients, one of the things that I always bring up in my new patient consultation is I say, I want you to sleep well. And that's why I basically wanted you to come on and talk to us about actually, what does that mean? Because we obviously live in a society that puts a lot of value in people being very busy and skipping sleep. So now that I have an expert to answer this question, I want to ask you, how much sleep is good for us to get each night?
A couple of studies that have looked at epidemiology, national-based data, such as the National Sleep Foundation, American Academy of Sleep Medicine, and two different publications came out around the same time a few years ago, and both really concluded that younger, healthy adults need somewhere between 7 to 9 hours. And as we age, actually, when you hit 65 and above, it really goes down to about 7 to 8 hours. So developmentally across our lifespan, and children obviously need even a lot more than that. So it goes down with age.
And what are some of the reasons why people should prioritize sleep?
There's a lot of reasons. Sleep's one of those interesting things that we study. As we sleep deprived, kind of healthy adults, we'll see more and more of like what happens. There's some theories, and we're starting to see links, associations, and correlations between sleep and health. So we kind of hypothesize and think it's related to immune functioning and helping us recover from illness, rebound from life's challenges. It also seems to help with kind of mood regulation and helps with kind of helping decrease depression, anxiety, things like that. And then it also has been shown to help memory consolidation when we've looked at kind of sleep deprivation and recovery nights, and we can see that there is some memory and learning that's related to getting a good night's sleep.
I'm an all the time person, and I'm a morning person. I'm a nighttime person. My husband is definitely a night owl. And and he doesn't have insomnia, but how is insomnia different from a situation where someone is willfully staying up late?
Yeah, you almost have three things there, because you have the person that could be kind of sleep depriving themselves. It's very busy. It could be on either end, the night or the morning. Could be insomnia, or it could be like you're describing as night owl is really what we call circadian rhythm and circadian disturbance. So there's a phase delay for some people that just their body clock is out of tune and out of sync with what society or life challenges are and social cues. Really, the biggest differences are your opportunity and your ability. So with insomnia, it's an ability issue. You could lay in bed, and typically my patients will lay in bed 10 hours or extend the time, and they're just not able to get the good night's sleep that they want to get. Versus the person burning the midnight oil, they're typically kind of sleep depriving themselves. They're not allowing themselves the opportunity to sleep, but given that chance, if I put them in a dark room, chances are they could catch up because they're more than able. They're just not giving themselves the chance.
Is fertility and the way our reproductive system functions tied to sleep? And if so, how?
This is a very good question, and I think it's still developing. We're still in the infancy, no pun intended, for this kind of line of research. We're starting to study it in terms of sleep and menstrual health, and then sleep and fertility. Looking at shift workers, there's a nice study that looks at nurses that were shift work, and that's tied to fertility and infertilities. So we kind of hypothesize a few things are going on. One is the sleep itself could be related to kind of if you're not getting good sleep or getting short sleep or very, very long sleep, it might be related to hormones themselves, things like follicle stimulating hormone, luteinizing hormone, estrogen, progesterone. So we can see that there's a relationship between sleep and hormonal functioning. So that's one thing. Another thing is sleep has really been shown to be related to the HPA axis and kind of cortisol and our stress hormones. And that itself could have an indirect link on fertility. Sleep's been related with immune functioning. I've done some of that work myself. So getting less sleep, short or disturbed sleep is related with higher inflammatory cytokines, things like CRP or IL-6, these pro-inflammatory markers that seem to be elevated when we're not getting enough sleep. And that could also have an impact on fertility. And then finally, just the circadian rhythm, that body clock, and melatonin seems to be also related. So there's multiple areas, but we're still kind of those causal mechanisms, and really kind of empirically studying it has been a slow process for us. So we're still working on it.
Yeah. And a few years ago, you did a sleep study with the Department of OBGYN at University of Texas Medical Branch to look at the impact of sleep on women. What were the findings that you reported for women in general?
Yeah, so we generally find that during these reproductive hormonal fluctuations, so whether that onset of menses for younger girls, for pregnancy, postpartum, menopause, those seem to be times of kind of hormonal shifts, and women are at higher risk for insomnia and sleep disruption during those particular periods. And given that, then what I do with the intervention that we'll get into a little bit more, but there's ways to kind of intervene and treat that in these different periods of life.
And then also during pregnancy, things can also change. How do sleep patterns change during that time, and what is the effect?
Yeah. So during pregnancy, by trimester, really, the first trimester, that's when hormones are big time starting to change, even though we might not see anatomical changes. And so we do find when we've looked at both self-report and when we do polysomnography and study their brainwaves and their sleep that way, that people tend to have poorer, more disrupted sleep. Sometimes they actually get more because across a 24-hour day, they may be napping and things like that and feeling the fatigue. Tends to settle second trimester. We tend to get the golden period, and sleep tends to improve as well during that time. And when women just report they feel better. And then again, that third trimester, now you're starting to get bigger, anatomical. You might be getting anxious about delivering and stress related to that. And so all those things also negatively impact sleep. So it's kind of trimester based. We have seen there's been a couple studies that if you can get better sleep, short and disrupted sleep were associated with longer labors and an increased odds of cesarean section. So it does seem to have things particularly related to health and obstetrics.
Very interesting, because that's our goal always. As fertility doctors, as OBGYN, educating of the healthiest birth outcomes. And now I'm 46. I know you can't tell, but I am.
I'm similar age, so I'll just leave it at that.
I keep the office really cold, and my employees that are in their 20s are just like shivering. Anyways, we know hot flashes are also a well-known side effect of perimenopause and menopause. How do things change for sleep during this time?
A lot of times, the hormonal shifts, the hot flashes. Typically, the median age in the U.S. is about 52, where people hit menopause. Perimenopause, that transition, the definition is 12 months without a period. You could have years and years of being in peri, and unless you tested and your people complaining to you that the office is very cold. But so that can last a while. But what we find is very interesting is sleep is one of the top symptoms that's reported started as a menopausal transition. However, it's one of the symptoms that doesn't abate. It doesn't spontaneously always relieve itself, where sometimes hot flashes will eventually stop, thankfully. But sleep, what we think is happening, or insomnia, is it takes on a life of its own. So it's how you stress about it and how you react to getting sleep is very behavioral, and what we're doing, I think of it like diet and exercise. So what you do consequently impacts that. And so there's a way to make it continue. The menopause itself and that transition and the hormones and the hot flashes may have brought it on, but it's how the women react to it that more people are actually complaining post-menopause, even after the hot flashes are gone. So it's pretty interesting.
I would love to hear what your tips are. What are your tips for women who are transitioning? Because a lot of my patients who are trying to get pregnant are in that situation as well.
Right. This is probably my favorite piece. I enjoy being a clinician helping people because it's actually, I wouldn't say easy. It's like diet and exercise, starting a nutrient. It's behavioral change, but there's things we can do to turn it around. The biggest take-home message for all my patients is you can't force it. You can change things, but it's like putting a square peg in the round hole. So the more you worry and stress about your sleep and work to make it better, count sheep, clear my head, don't think, that's going to make it worse. And so it's not until you give in to what's going to happen and accept where your body is at. And so then there's a couple tips to help it along. We have things, don't be doing a lot of activities in bed. The big one is if you're laying there and you're unable to sleep greater than about 15, 20 minutes, and I do this myself, if whatever wakes me up, if that wakes me up, if I'm stressed about work or something, I may not be able to get back to sleep. My brain is actively working. Don't just lay there frustrated or staring at the ceiling or counting sheep. Get out of bed and go do something really relaxing and sleep promoting. I'll watch old repeats of Golden Girls. I don't read the news because that stresses me out, but I do like to look at interior design. So I look at articles that way, things that are relaxing, and then clearing your brain. Then when you feel sleepy again, get back into bed at that point. Keep the same rise time no matter what, good, bad day. Keep your good body clock and your rhythm. And that way, people are actually often afraid of, we actually do sleep deprive people to build their sleep pressure and their sleep appetite. And so if you don't get a good night's sleep tonight, don't worry about it. Don't stress about it. It's not about tonight. It's about this bigger picture. It's about chances are tomorrow night's going to be better for you. Or it might take a couple days for your body to get with the program, but really not stressing and actually decreasing the amount to what your body is able is really the magic of it.
And then let's say you don't get a good night's sleep and now you're dealing with insomnia. What do you recommend for people who are now dealing with the negative effects of not getting a good night's sleep the night before?
People tend to habituate it over time. When we do neuropsych test studies of testing memory and things, we really very rarely can see the difference because people can rally and compensate for a bad night's sleep. So knowing about that yourself, that you can probably push through, mitigate breaks. I mean, it's hard. For me, I sleep pretty decently. I follow these rules and guidelines. But there's nights where I'm not, and chances are it's the night where I have to catch a flight early or I have a very special meeting that your body's telling you something important is happening. And that's fine, realizing that. And I still try to push through. I tell myself, yeah, you can perform anyways. No one's going to know. I can probably trick most people and push through, but keep your same routine. Don't react in a negative way. I know it's easier said than done, but trying not to stress about it and trying not to be reactive. Never compensating for a poor night's sleep by either sleeping in, irregular sleep schedule, or napping are the opposite of what's going to help you. So
got it. So I just put up fingers in my office. I say I'm on 5 hours or I'm on 4 hours because they know when I'm at 5, like the tiniest little sounds, like even the clicking of a pen, it's like someone is playing drums in my ears or like crashing cymbals in my ears. And so I'm super sensitive to sound. Oh, I can rally and push through, but those are the little things I just have to warn people around me.
You know yourself best. I have trouble making decisions when I get that way, so there's so many different ways it can creep up when you had a poor night's sleep.
And you've done a lot of research on CBT interventions. How can that help? And how does that play a role when you're on your period or in pregnancy or dealing with perimenopause and menopause?
So some of these tips are part of the CBT, the getting out of bed if you can't sleep. And we actually tend to restrict sleep for a couple of weeks to the amount of time your body gives you. So if you're only able to sleep 6 hours, only stay in bed 6 hours for a couple of weeks and see if that helps you reset. Those are the behavioral, the CBT. The C stands for cognitive, which is I help people try to figure out how to quiet their mind of if you're tired but wired and your brain is just going. So we do things like mindfulness meditation or trying to bring closure to your day and kind of a relaxing, unwinding period and things that can help with the thought process. The behavior, I already told you, get out of bed anyways if you can't sleep and get up at the same time. Those are behaviors that you're doing that are going to help. The book that we put out this year for providers was adapting CBT for these different conditions. So one of them in there, I wrote the chapter on menopause and a good colleague wrote the chapter on pregnancy postpartum. And so we do think about for postpartum, if women are being disrupted by childcare and things like that, how do we adapt for that? Do we tend to a lot more time in bed than you would because you don't want it to be the time that you're taking care of feeding. For myself, I did the study at UTMB that looked at it for menopausal hot flashes. And so we gave a lot of education around what the hot flash looks like. For instance, it spikes within 30 seconds and the whole hot flash itself will be 5 minutes. And so it takes about 20 minutes for the body to cool. So realizing those things and like some sleep hygiene things of ice water by the bed and sweat wicking pajamas or maybe a towel or things to mitigate what's going on. So there's ways we tweak it for different conditions that are going on with women and what's going on in developmentally in their lifespan of at that point in time.
Yeah, I sometimes, unfortunately, have to induce these kinds of symptoms in women. I call it devolupron, but it's actually called depolupron. And hot flashes are one of those side effects. So hearing these little tricks that you've suggested, I think I might be using those in the future.
Yeah. We've actually, there's studies, especially out at Harvard, they've done a lot that they actually give it to people on purpose to study their sleep and hot flashes and see what happens. So I'm like, yeah, that's kind of evil.
I have another fascinating study that looked at how insomnia may be tied to the risk of a pregnancy miscarrying. Can you explain a little bit about that study and what you learned?
So that study was very interesting. Now, for that study, it's one of my dreams of different areas to study is to actually just partner with fertility and endocrine and do it what we call prospectively or collect sleep while we're like collecting these other hormones. But for that, the best we were doing is we were looking at epidemiology data. We used this data set called NHANES from CDC. They collect all this information. And part of it in their survey every year is they have sleep questions in there. And so we were looking at sleep and what are other women's health questionnaires in there. And so the best we could come up with that was related to fertility was actually pregnancies that didn't result in a live birth. That could have been that they chose, right, to electively end the pregnancy. So it's not exactly one-to-one of fertility, but we did find that people with shorter sleep, less than 6 hours, and disrupted sleep, self-reporting disrupted sleep, it was related to higher levels of pregnancies that didn't result in a live birth. So it just gives us what we call kind of hypothesis generating that then we would like to do these bigger studies to look at, is there something there and is it really meaningful? And actually, should women be paying attention to this, that it's as important as their diet or stress or other things that we tell people about.
So if I have a patient that works a graveyard shift, especially in a woman who's had a history of miscarriage, I'm going to often ask her to change her work schedule and do what she can to get a healthy amount of sleep. So thank you for doing this work. And I also see that you've looked at acupuncture as a way to help people who suffer from insomnia, specifically around menopause. And I actually recommend that my patients consider acupuncture as well. So how can acupuncture help someone with insomnia?
Yeah, there have been several trials, and there's actually even studies that then analyze all the trials or do these systematic reviews and meta-analysis. And it does show that acupuncture seems to help people with insomnia. So they would like to collect more data and do bigger trials, but there's definitely something there, a signal that it's helpful for people with insomnia to treat it. And women, and we've done it in like menopausal women and in different groups. There's different thoughts on the mechanisms of why. So we know acupuncture can impact neuroendocrine, things like GABA in the brain or serotonin or potentially melatonin. By impacting those things and maybe bringing down stress too, and the whole process of that, I could see it being very helpful, for sleep, and then also for fertility too, that it just seems like a generally good guideline. We kind of weigh these studies, and when we don't have quite enough, I just tell people some things just, we haven't done the trials, especially for like herbal supplements. We just haven't done all the trials to know if it's going to be helpful or not. So use your best judgment, be an educated consumer, and you may consider them. Even things, we know the power of placebo is super strong. And so that alone, if that's changing your mindset somehow and helping things, like that's great. I tell people, I don't really poo-poo what anyone's taking, what they come in telling me they're taking. So.
Right. And I think what you're referring to is probably like melatonin or CBD or THC.
Correct. Yes. And I didn't mean to imply that acupuncture was in that group, but particularly, things like CBD that we just don't have much data yet at all. Melatonin, we actually have a little bit more, but we have found it's very good as a chronotherapy. So you describe your husband as being a night owl. If you take it, it's not as much the dose. It's actually kind of a microdose, like a 0.5 milligram to 1.5 milligrams, but taken about 5 hours before sleep onset. So a good period before it, you can pull your rhythm in your body clock. And so that's when we tend to actually therapeutically recommend it. There's certainly some ties to fertility with melatonin as well. Still a lot needs to be studied, and so we can get some definitive answers, but all very interesting.
Yeah. And we've gone through so many specifics, but I'm very curious if someone is wondering if lack of sleep or insomnia could be impacting their ability to conceive. How can they get a diagnosis and then also treatment?
Yeah. And I do like that you said like educating doctors, because I think that is a big thing, and especially not just fertility. So insomnia and poor sleep tends to be underreported by patients, and it tends not to be asked a lot. And so it doesn't receive the kind of proper diagnosis it should receive, just because there's so many other things to cover. But yet here we are seeing it's at least kind of a lifestyle. At the very least, we might as well be improving women's quality of life. And at best, perhaps we could be improving fertility by doing these things. Physicians asking about it, patients knowing about it, and telling their doctors when they're having these issues. 2016, the American College of Physicians actually recommended the CBTI as the first line of treatment for insomnia above and beyond medications, because they tended both to work in trials in the short term, and in the long term, it actually worked better to learn the behavioral skills. And people like me that are trained in it, I do behavioral sleep medicine. We can be hard to find. There's not a ton of us out there, but there are definitely even resources out there. In fact, one that I like to give patients a lot that's free that any of your listeners or viewers could take is if you Google VA insomnia workbook. There's a very beautiful self-management workbook that was created based on empirical data and by the experts in the field. It was created for veterans returning home from war. However, it's not very specifically tied to the VA or to veterans. So really anybody that's looking and wants a self-management program to get some more tips about sleep, I think that might be a good place to start.
And when does someone need to see a sleep specialist?
If it becomes big and problematic. So the diagnosis for insomnia disorder is it occurs 3 nights a week for a period of at least 3 months. So if it's ongoing and becomes this chronic problem of sleep disruption and you just can't get a handle on it, that might be a time. Any sort of loud snoring, partner jabbing you, gasping for breath or waking yourself up like that, it tends to go up during pregnancy too, because we're changing anatomically. So it's good to get it checked out. Another big symptom is excessive daytime sleepiness. So that daytime, if you're just like wiped out and unrefreshing sleep and just can't get a handle on things, it might be a good time to see someone, or at least bring it up to your regular provider.
And what do you wish fertility doctors knew about the relationship between sleep and fertility?
Looking at correlations, it seems like that there is a relationship, and it would probably be smart to ask about it and make referrals if needed, and maybe learn a few of these tips themselves that they could kind of provide to patients, or some of the free online resources that we have, and just try to recommend people get a good 7 to 9 hours sleep is what you're aiming for. We're not fully sure if we treat it or if we get the better sleep. It's not probably going to be this magic panacea that it's going to cure all unknown fertility or other, like we don't expect it to cure everything, but it certainly could help quality of life and potentially has some benefit there.
I know as a fertility doctor, I have my own special supplement that I like to recommend, or a diet. Like, as a sleep specialist, especially with all the studies that you've done, do you have a sleep monitor that you tell your patients to use, or a special like eye cover to wear, like a mask, or a special curtains that they can be getting to darken the room?
Yeah, I don't think I have. I'm not tied to any specific products. It's really like what works for them. So it's working through the big things are really for the CBT of like just not staying in bed if you're not asleep. Don't try to torture yourself. But other than that, those other things can be kind of like icing on the cake and can help or hurt. I use all kinds of things. I use aromatherapy at night. I have a little tinnitus, so I listen to white noise and nice Alexa. I have blackout curtains. I have a weighted blanket. So I think those things can help. Those things are like kind of sleep hygiene. And I think of sleep hygiene like I think of dental hygiene. Like you brush your teeth every night to prevent cavities, right? But if you've got a big cavity in your molar, brushing your teeth all the rest of the world is not going to, like for 24 hours a day is not going to get rid of that. And you need to go see the dentist. And so kind of same with this, those things can be very helpful. It may not solve all the problems if we have the insomnia disorder going on or something bigger.
Thank you so much for all the work that you're doing. May I ask, if someone lives in your area, or I'm not sure if you can see people out of state, where can people find you and learn more about your work and even work with you?
Yeah. So I do not practice out of state. I'm in Houston, Texas, but I can practice in pretty much anywhere in Texas since thanks to COVID. Now we're doing video visits just like this, really. I can do all the interventions via video. So that's lovely. I'm at Baylor College of Medicine. If people just Google my name, Sara Nowakowski, they'll be able to find all my information on that. My Twitter handle is Sara_Sleep, Sara Sleep. So they could follow me there. And if they're looking and want to see my work, I think the best place I tell lay people to the community to do it would be like, look under Google Scholar, type Scholar into Google, and then that pops up. And then if you write my name in there, you'll see all my articles. They just pull up. They're all open public access now. I get my funding through NIH. And so we're kind of accountable to the taxpayer. So all that information is available to look at.
That's wonderful. Thank you again, Sara. Thank you for your time today. And I appreciate you and your work so much.
Thank you. Thank you for having me. It's been a pleasure.
Thank you so much for listening and making the Egg Whisperer Show a part of your weekly routine. To find show notes and a full transcript for this episode, visit dramy.org and look under the blog tab. While you're there, you can find a link for the Egg Whisperer newsletter, which keeps you in the know about fertility news. You can also find Dr. Amy and the Egg Whisperer Show on YouTube, Instagram, or Facebook. If you'd like to learn even more, Dr. Amy offers classes at the Egg Whisperer School, eggwhispererschool.com, or you can request a consultation on dramy.org. Thank you so much for tuning in and for sharing the Egg Whisperer Show with others. Keep sparkling and have a great day.